The way we're going to work today is I'm going to invite Catherine to just give us a bit of scene setting and reflect on things briefly. And then I'm going to talk for a bit. Then I'm going to invite you to come in. But this time I want to ask John to be very active in the debate, and don't hesitate to come in early and late if you want to, because I think it really is an interesting time to be asking ourselves, what is the type of leadership that's needed to help us navigate the present situation? A special shout out to Frank Atherton. Frank will be giving you some space early on. If you don't mind listening to me for a little bit at the beginning, Frank, that will help me to get my own head in order. But I'd like to bring you in quite early. Is that okay, Frank? And can you stay for the full hour, Frank?
I'm afraid only half an hour today, David, but yeah, I'm very happy to listen to the general overview. Thanks.
Okay, half an hour, so I shall be super fast with my introduction. I'm talking a little slowly because there's still one or two people joining. Gregory Hartle, thank you. We hope that you'll be able to be active participant in this, especially given the incredible effort that you've all been making in WHO to get Tedros's voice out strongly on long COVID. And many people on this Zoom have had something to do with that process of raising the profile of long COVID. And yes, now we've got the WHO Director General in The Guardian, fronting what has become quite a long and deep set of articles that involve several of the people who've been in our open online briefings. So this is very good news indeed. And so thank you. And Gregory, we'd like you to be talking away. Magan Mutefa, joining us as usual from Gaborone in Botswana. And I just wanted to, oh yeah, Karen Kaplan, thank you for joining. And Annie and Keith Appleyard, I really do hope that your COVID is basically saying bye-bye to you now, but I know that it's not been a very nice COVID at all. Catherine, over to you.
Thanks so much, David. Mindful that we have people who will have to step out a little bit early, I will keep my comments super short, just to remind everybody that this is being recorded. You probably had to click a button when you signed in. And we plan to put it onto the 4SD website. If you say anything, you're welcome to say anything you want, but please let us know if you'd like us to edit anything out. We certainly can do that before it goes onto a public website. In the meantime, I guess my only words are ones we've heard a million times before, but COVID is still here. Seems like it's here to stay. The best we can do is try and make sense of it and be good systems thinkers. And with that, over to David, who is surely going to give us more inspirational words than that.
Super. Could you just, I mean, it's 17:35 European now. My opening framing will be 10 minutes, plus or minus one. And then we will invite Frank Atherton to come in. We will also invite Gregory Hartle, and then we will open the conversation. Ray, when I talk, you will hear that I'm talking to you. And I know also that Claire, C-L-A-R-E, would have liked to have joined, but couldn't because she's struggling with more COVID in the family. And so could you be the main talker on long COVID today, if you like? It may be that we will be joined by Maria Van Kerkhove, but she's not on yet. As soon as she does come, I will give way and encourage her to speak. I do want to say hello to Terry Skubdal, hello, and to Ian Boyd, to Polly, It's super to know that you're here, Polly, and Anne and Keith are here as well. And to Will Ramsey, very excellent. And to Nigel Lloyd, I just saw you. So here are my headings. Number one, there is no doubt that another surge of COVID infection is coming into societies in Western Europe with a vengeance. And we know it, all of us, not because the statistics on new cases are super helpful. The fact is that a lot of people are getting COVID but don't know they've got it. And a lot of COVID is happening and it's not recorded. And we pick it up from hospital data, we pick it up from community-based surveys like is done in some countries. But yes, there's another surge. And right now it looks as though it's Omicron that's making a comeback. And it's a variant of Omicron. What we do not have any evidence of at the moment is there being a higher rate of morbidity or death associated with this new surge. I think that most senior professionals are quite nervous about the coinciding outbreaks of influenza and COVID in the Northern Hemisphere. Some are concerned that because people are feeling that the whole thing is calming down, the uptake of additional vaccination, the second booster as it's called, seems to be less than is ideal, but especially in older people, the people who are most at risk. So it's a tricky one to really handle from a public health perspective, especially as for lots of reasons, the last thing any government wants to do is to act in ways that diminish economic activity. And so there's a lot of pressure to just keep things going. My line is quite straightforward. Nobody should be getting COVID if they can avoid it for all sorts of reasons, which means if there is an increasing incidence of the virus in your area, you should practice the public health and safety measures that we know work. That means physical distancing. It means mask wearing, especially if you suspect you might have the virus, to try to stop you giving it to others. And it means testing and isolating if you're positive, and then trying to inform your contacts and making sure that they're able to isolate as well. And that's all because my second point is that even if the COVID that people are getting these days is much less severe than what we were experiencing a bit over 2 years ago, the reality is that about 1 in 20 is getting prolonged COVID, and that is associated with prolongation of the symptoms, plus also raised risk of subsequent morbidity and mortality associated with whatever pathologies a prolonged exposure brings. And given that we believe that one of these pathologies is the capacity of clots to develop because of damage to endothelia and a number of other phenomena, the long COVID phenomenon may well, in part at least, be associated with microclots in the bloodstream, which can in turn impact on what's happening in the lungs, particularly the upper part of your lungs, or it can impact on what's happening in your head if you've got some hypoxia and damage as a result of little clots going off, or it can even give rise to damage in other organs as well, such as the kidneys. And our long COVID understanding is evolving at an absolute rocket pace, and it feels like this: more than 100 million people with long COVID, with evidence that they have a higher risk of cardiovascular, cerebrovascular, and lung challenges, plus a higher instance of mental ill health. And altogether, this is absolutely massive in terms of its potential for humanity. It needs research in order to be able to identify the therapies that will work effectively. But most importantly, people who say after their COVID, they've got continuing symptoms need to be heard and, in my view, need to be believed and not fobbed off. So there you go. We will talk a bit about that. It's just such a huge issue, and I want it to continue to feature in our conversations. The third thing, a point I want to make is that my work with the Global Crisis Response Group, organized by the UN Secretary General, is showing me over and over again that the fabric of societies all over the world, particularly the societies that enable poor people to be able to survive, often in the informal economy, that fabric has been damaged. It's as though the weave of the fabric has loosened and people are more easily able to fall through the cracks. And this damage to the fabric of society, the loosening of the weave, is resulting in a real lack of support capacity in poor societies in all nations. I was just recently in Thailand and picking that up from people in the informal economy in that country. But I've also recently been in a number of different European countries and getting the same message, that the systems that enable poor people to keep going, and that's perhaps 3 or 4 billion people in our world, have really been stretched. And then my fourth point is just to say that that is associated with the wider cost of living crisis that's affecting nations everywhere. And just because many of you are interested in that, my current focus is on the deepening food crisis affecting many millions of people in about 6 locations around our world, particularly in East Africa, as a result of accelerating climate change on top of COVID-19, on top of conflicts, and in countries and societies that have very limited amounts of cash, who are in heavy debt. And the world is not coming in a concerted way to support the many millions of people who are in near famine or famine conditions. We've got the worst and most difficult, and frankly, as far as I'm concerned, the most intractable crisis that I've ever known. And I'm not sure how widely it is understood just how bad this is for people in all regions. So my friend Elizabeth Simondala, who I was with in Rome earlier this week, who's a Ugandan farmer in Kasese, was saying, we have people dying in Uganda, there are people dying in northern Kenya, there are people dying in Ethiopia, in Somalia, Djibouti, Eritrea, of starvation, of famine. And it's at least as bad as it was in 2011 and 2008, and much worse than the famines that came in the decades before. And it worries me a lot. Okay, so that's my brief introduction. And I'd like now to go to Frank Atherton and Claire Rayner. Both have to leave. Frank first, then Claire. Lovely to see you. Claire, I got a horrible feeling you're in a hospital, but can you stay for 14 minutes, or is that impossible, Claire? Yeah, thank you. Frank first, please.
Well, thanks very much, David. I'll be very brief because I'm sure a lot of people will be wanting to talk today, David. So I mean, in Wales and the UK more generally, again, I talked with all the CMOs this morning, and our picture is exactly as you describe it, David, which is that we're in the midst of another surge. I've been watching the rates in Wales go up, and we're fortunate here. We have the ONS, the Office of National Statistics, gives us a pretty clear estimate of the prevalence, and it's gone from over weeks. It's gone from 1 in 100 to 1 in 80 to 1 in 50, stayed at 1 in 50 for a little while. Yesterday it was 1 in 40 of our population. So just over 2.5% of our population are actually infected. So, high numbers, a lot of community transmission still. You're right that the hospital sector isn't particularly overloaded with the direct COVID pressures. But having said that, we've got, well, in Wales, we have about 10,000 acute hospital beds, and nearly 1,000 of them, the patients have COVID, but only about 2% of them are actually actively being treated. So there is a bit of a mismatch there. The rates are highest in the more elderly, and that again reflects the fact that we need to watch that, because there's always a lag, isn't there, between the community rates going up and the hospitalisation and the harm that comes down the road. Fortunately, in the UK, certainly in Wales, our ITU figures are rock steady. There's not no harm, let's be honest. There's still harm accruing. We have 8 patients as of today in hospital in ITU beds. So there's still quite a lot of damage going on. The difficulty, of course, is that the attitude of the general public, everybody wants it to be over. We all want it to be over, don't we? And so there, I wouldn't say it's complacency, but there is people have a certain bandwidth, don't they, David? And there's all these other pressures: the cost of living, the fuel crisis, the economic upheaval that people are going through is really occupying people's minds. So it means that getting vaccines into people, and we are embarked, of course, in the UK on a serious program of trying to get autumn boosters into people who are eligible. That's the more vulnerable. It's not going quite as well as I would like. There's a bit of, it's not resistance, it's a bit of failure to uptake quite as we did in the previous waves. I think some of that is that the systems that we had to give vaccines quickly and effectively to massive numbers of people have been wound back a bit. So making vaccines and access to vaccines really easy is quite important to people. So that's kind of where we are, David. And I think we're going to be in this position probably for quite a few weeks now. I'm not seeing this as a wave that's going to go up and quickly come down. I think we're in a kind of an undulating plateau of infection now that we're going to have to manage and work with our public, work with our communities, get the vaccines into people. Just one word, if I may, David, on the fact that we do have, we're not seeing large numbers of deaths, but people are still dying. Let's be clear. And we do have in the UK an excess mortality compared to what we would normally have this time of year. And there's all sorts of reasons why that might be. One is that there may be some misclassification. People may actually be dying, 3, 4, 5 weeks after they've had COVID from those complications that you were talking about, the clotting effects, etc. There's almost certainly a bit of an impact in the summer months that we had of the heat wave, and we know that heat waves lead to excess mortality. But more fundamentally, and what I'm worried about, is that some of the pressures that we see on our healthcare system, which partly are COVID, but there's all sorts of other pressures, mean that people are not getting access to the care they need, and there may be some effect from that. And also, one of the things that slipped during the COVID time is secondary prevention. Getting good secondary prevention back up and running through primary care, through secondary care, making sure that people have access to statins where they need them, to antihypertensive medicines. And so some of that has slipped back, David. And I think, if we can correct some of that, we'll start to address some of this excess mortality. So a difficult position. You're right about the face coverings and the distancing. Those are messages we absolutely need to keep pushing with our communities. If I'm very honest, here in Wales, it's a really hard message. You don't see many in public places, but as rates go up and if harm starts to accrue more, we absolutely need to double down on those messages. Thanks, David. I'll stop there.
Thank you, Frank. There was an interesting piece in the BBC, you might have seen it, report from the Director of Public Health at Cwmtaf Morgannwg Health Board. I think that's in
Correct. Yes.
that's in the mining areas, saying the cost of living crisis is doing exactly what the COVID crisis did.
Yeah.
I mean, it must be very difficult in parts of your region where you have people who are poor and there's relatively little that they can look forward to as options for increasing their income at the present time. Am I right, or am I being?
Just on that, David, you're absolutely right. You know, and Kelechi, thank you, John. Kelechi is a very talented director of public health up there. It's a valleys community.
Yeah.
It's relatively poor. Well, quite significant. They have high levels of deprivation. They've been hardest hit in the pandemic, and they're hardest hit now. And they've got all of these additional pressures coming on them around cost of living, so that hits them hardest as well. So you've got this kind of double whammy going on. You know, really, really difficult circumstances.
Thank you very much, Frank, our very great friend who is looking after public health in Wales, and it's wonderful to be connected with you. We now go to Claire Rayner, who's been with us since the beginning of these briefs and who has been a very active advocate on long COVID. And it is an honor that you've joined us. And I'm sorry that you are right in the midst of some personal stuff, which you are welcome to talk about if you like. This is a community of friends.
What I might do is turn my video off because my connection's a little shaky, if that's okay.
Understood. Yeah, thank you.
Yeah, so I'll briefly speak to the acute situation and to some comments that you've asked me to perhaps express today. My niece who's 19, 3 weeks into university at London. I'm here with her in UCLH Hospital in London. She's perfectly fit and active girl, but day 4 has developed chest pain. Unfortunately, she's very sporty, and I had advised, please don't exercise during acute COVID, but she felt forced to. Anyway, she's now got low oxygen saturations. They've already come out and given her antibiotics, and she's probably, well, I'm concerned that she's developing a myocarditis. It would be a classic history in the circumstances. In the waiting room here, they're being absolutely fantastic, and very efficient, but it's full of people either looking sweaty and pale and about to keel over or coughing their guts out. So that's the acute situation. I really would love to get the messaging absolutely right about please do not exercise in the first stages of COVID. I can't emphasize it enough. I will briefly speak to, we emailed, and I said that some of us are facing, in terms of long COVID, some really quite significant difficulties of being got at. I'll put it that way. So some of us that have been active in explaining what the health problems actually are that are prolonged, are now facing, you know, I'm saying this and it's quite, I'm being quite open, but I think, David, you probably got reasons for asking me to do that. I have, you know, the things that I've written for the Society of Occupational Medicine about the nature of the conditions and, you know, the medical aspects of it. I'm getting attacks, you know, emails questioning things. In that way, I'm being called to account for these things, and it's all rather subtle and not very pleasant. And others that I know, their jobs are very subtly and carefully being threatened. And I probably don't want to say more, and I know that you will have reason for asking if I wanted to share that.
Thank you.
It's very difficult.
I'm grateful to you for sharing it. I'm just wanting to tell you that every time I do a radio interview, there's a small number of people who think that it's okay to send me emails and other communications that are really unpleasant to a form that I don't recognize. Now, I know Frank has got some of this, and I know that Chris Whitty got it as well. It's become a sort of legitimate behavior for a group of people who might see themselves as those who've identified the conspiracy that's going on here, and who are taking the line that people like myself, and I think possibly Claire Rayner and Ray Duncan and others, are sort of enemies of the people, that we're not actually interested in public health. We're interested in sort of things that are bad for humans, almost satanic. And they've got this view of us. I mean, perhaps you all know some of this, and it's become legitimate to talk and behave like this, and to confront people working in public health with these sorts of accusations, and none of us can actually shrug it off. Partly because the language is subtle, and as Claire just said, it niggles away at you, and partly because a whole feature of our existence as people working for public health is that we're working for the public good. And so it sort of offends us to get this treatment, to be told that we're satanic, we're part of the genocide, we're this, we're that. That's what I think it is, Claire. And if that's what it is affecting you, you absolutely don't deserve it. And it is so important that at no point, even when you're feeling as low as you might feel in your whole life, you never allow this stuff to let you question the basis of your existence and your value system and what you stand for and what you've stood for ever since I've known you. So hold strong, and we'll all be behind you. Thank you. It's probably stronger than I meant to be, but I just want it to be unequivocal. Unequivocal. Ray, please. We're going to ask you in a minute. I'll ask you to come in now. And anybody else who needs to leave early, put up your hand, or put up your physical hand or your digital hand. But otherwise, I'm going to go to people who I know want to speak.
Thank you, David. For those of you who haven't met me, I'm Ray Duncan. I'm a cardiology consultant that's been involved working in the field of COVID and long COVID since the beginning of the pandemic. I'm also working in long COVID research. I'm also a pretty strong advocate because I've run a clinic for a long time, and I have a lot of patients who've been very, very sick. And I just wanted to firstly say that I agree with absolutely everything David said. I agree with absolutely everything Tedros wrote in the Guardian article. I think it's brilliant that the WHO have come out and said what they've said so strongly. I just wanted to pick up on some of the things that Frank mentioned earlier. So it's about complacency within the population. I don't think there is complacency. Everybody wants it to be over, but it's not really the public's fault. If they're not being given the correct public health messaging, they're not going to know all the stuff that we know. We know all this stuff because we're researching it every day. I have read thousands of papers. I am writing papers. I am setting up trials. I am seeing patients with this condition every single day. I am seeing what their blood vessels look like under a microscope. Most people are not in the privileged position that I am in. They're not seeing what I'm seeing, and so they don't know it because it's not affected them. And if you don't know something and nobody's telling you, then you don't know that you need to protect yourself against it. And I think we have to get away from this narrative that I mean, it's good in a lot of ways that the death rate from acute COVID is going down. That's fantastic news. And it's a really good achievement with all the vaccinations, but it is not stopping the disability rate going up. And we're seeing so much disability and ill health now. And it's not just in people with long COVID. Even if you have clinically recovered from COVID, statistically, you still have an excess and increased risk of cardiovascular complications and neurovascular complications. children have got double the risk of developing diabetes. There is evidence in children now of subclinical organ damage in the lungs in children who've clinically recovered. This is very concerning. And I don't think it's okay just to accept this as the COVID rates are going up. This is partly preventative. Vaccines on their own are great, but they're not enough. Being vaccinated only reduces your personal risk of developing long COVID by 15%. If you are repeatedly reinfected, we know that reinfection cumulatively increases your risk of developing long COVID. We have to be doing things to get the message out there that this is not okay. And personally, and this is just my personal opinion, but one of the things I think as nations across the world we really need to be focusing on is clean air and air filtration. We did it years ago when we cleaned up our water supplies. We would never knowingly allow our citizens and our kids to drink out of taps infected with cholera. So why are we still allowing them to go to schools full of COVID in the air when we've got the data that already says putting air filtration into schools reduces COVID outbreaks in schools 12-fold? And in the long run, somebody needs to do a cost analysis. I know individuals and world leaders are worried about the economy, but the economy is going to be far worse off if half of its citizens end up disabled. And, you know, there's already data coming out of the US saying that it's costing the US $2.3 trillion. There's data coming out of the World Economic Forum suggesting that COVID's already cost the global economy $11 trillion, and it's estimated to cost another 10 trillion going forward. We can reduce that if we put in sensible mitigations. And the best way to reduce the incidence of long COVID is to reduce the reinfection risk.
You are the most brilliant communicator. Please come and join us anytime. We will offer you the space, and we will do everything we can to enable you to have the opportunity to spread these words. Whether we can do it at the timing that's needed, I'm not sure. I mean, the truth is that your message needs to be heard and heeded by every government in the world now. And if we can't get it done, then we need to all recognize that we are making possible a situation where increasing numbers of people are going to be facing increasing risks of cardiovascular and other diseases. And we at the moment do not have a preventive therapy that works. Ray Duncan is one of the people in the world who will be the first to find it.
I hope. No pressure.
No pressure, my love, no pressure. But
yeah.
It's tricky. And I know that, like Claire Rayner, you are not finding this an easy journey. There are people who are inconvenienced by what you're saying. As Al Gore would say, it is an inconvenient truth. Mm-hmm. What can we do to help?
I think Tedros coming out and saying those things publicly is already a help. On the back of that, I've already got meetings with politicians in the UK to discuss the issue and try and get some of the word out there. I mean, I'm only one person. I don't know if it'll make any difference, but at least I'm trying. I think having a clear, consistent message to leaders in all countries that economically, as well as from a health burden point of view, if they do not wish to see an economic disaster unfold in their countries, really there needs to be money put into preventing COVID reinfection everywhere. And it needs to be a coordinated approach. And I think it needs to come from the WHO. And I think, you know, air filtration systems are a good start. Masking indoors until we get them in place is very useful, as well as vaccination, because doing one thing in isolation, we've already shown, is not enough. It's not that we shouldn't do it, we should absolutely do it, but on its own, it's not enough. And I'm also a little concerned about some of the new data coming out about one of the Omicron variants, the 1.1, which you may have read one of the research publications about this, appears to have a particular predilection. We've talked about endothelitis, which is inflammation of the blood vessels, which is what COVID can cause. This particular variant appears to, from the early data we have, be causing an endothelitis that has a predilection for the blood vessels in the gut. Now, as a doctor, that is very concerning because the gut is full of bacteria and the bowel is very sensitive to ischemia. Ischemia is the medical term for not enough oxygen. So when the gut doesn't get enough oxygen, bits of the gut die and those bacteria get released into the bloodstream and people can die of sepsis. And that's one of the things that's coming through with this new variant, that people are dying of septic shock. And the variant appears to be showing some immune escape, which is concerning. So again, prevention absolutely has to go hand in hand with vaccination.
So I'd read about the gastrointestinal impact of that variant. I hadn't grasped the potential seriousness of it. I think we must hold on to that. Everybody, we are people here who talk what we believe to be truth, even if it's not good news, and we don't sugarcoat. We support each other in coping with this not good news by sticking together and connecting every 2 weeks. We know that we will be here in that support role. It's super important, not necessarily all the time, but some of the time. Now, there are several of you who have written comments, and we'll come to those. But I did say that I was going to come to John early as well as at the end. I just want to ask you, John, is there any observation you want to give on what you've heard so far?
I wanted to pick up, David, on what you were saying about the weave of society, and that damaging the weave means that all sorts of people start to fall through, to not mix too many metaphors. And to say in leadership terms, paying attention to that weave, how we connect to each other, how we relate to each other, how we care for each other, is an absolute essential leadership activity, not just on the sort of national scale in communities, but in businesses as well. It's how we get anything done. Because when you look after that weave, it gives you an amplified capacity to act. Every message that you get can get transmitted that much wider, that much further, that much faster, with that much more sense attached to it. So that when we're saying the things that we're saying about what's going on, it sticks and it gets passed on and it gets passed on. And without that amplified capacity to act, everything requires an extra element of direction and control, which requires energy, it requires cost, it requires attention that, frankly, politicians, particularly at the moment, but also others, want to attend to other areas. So I think we need to not be shy of calling out the damage to the weave, because the social fabric of society, because it is a prerequisite for an effective response to an evolving disease. And when you damage that weave, and sometimes quite deliberately for short-term gain, setting one group off against another, looking for immediate popularity, it reduces your capacity to get anything done in the longer term. And there's a phrase we use in this work, which is the way that you get to the future is the future you get. If you set about doing things in a way that is damaging and harmful, then you will get a damaging and harmful future. So I think this message of encouraging us to look after the social fabric of society as a prerequisite to all the things we want to do is really important, David. I'm glad to hear you sharing it.
Thank you, John. And just to build on that from one perspective, there is now a group who are being very clear that a strong societal weave leading to good social capital is key, both for the mental health and well-being of societies and for the organization that we all need to be able to tackle the climate change that we're experiencing right now. I'm rather pleased to hear that sort of logic emerging, because it's very much what we said 2 years ago when COVID was really picking up. And we said it's going to depend on the connections in society, as John just said. Thank you, John, as always. Going to go now quickly to the people who put comments in the chat, and anybody else who wants to come, just wave and stuff. But Marion Hazelgrave, please. It's always lovely when you're here. I mentioned my Uganda friend earlier this week because I know you've been in Uganda recently, and a lot of your examples come from Uganda. Would you like to say anything, Marianne?
Yes, I would actually. What the UN Secretary General is doing is perfectly fine, but it's not going to hit the mustard, so to speak. That's a mixed metaphor, I know. The main point is, until governments show leadership, things aren't going to happen. Now, I mentioned the G7, I mentioned the G20, because there is a total lack of leadership on trying to see the issues as they're happening. And COVID-19 is a wonderful scapegoat in this regard, as far as all the other problems are concerned. We cannot blame everything onto COVID, because there are so many other issues that are interwoven, but it needs countries to take the leadership. And the question is, where are those countries going to come from? Which one is going to be brave enough to step forward? There is a possibility that I mentioned of this summit that's going to take place next year on the implementation of the Sustainable Development Goals. That's been called for. It'll be at the UN General Assembly level. And we have to start now to make sure that at that point, something really begins to happen, because the whole 2030 agenda is off track. The world is, as they would say, going to hell on a handcart. But without political leadership, it's going to be extremely difficult. And what we can do is to try and work for that. But there's no point in looking at this country, i.e. the UK, because it ain't going to happen here. Thank you.
Thank you very much indeed. Hang on just a second. Sorry, this is urgent. David, can I? Right. Thank you very much indeed, Marianne. Just to say, this is where the UN Secretary General is at the moment. He's looking super hard for leaders who are prepared to take this seriously. But having just been at a thing called the Committee on World Food Security in Rome, Ad Spikers was connected remotely from Vietnam. He will have seen it. We had a discussion on the current awful situation with regard to food, linked to fertilizer, energy, and finance, but it was impossible to get an agreement because of the desire of the countries who are positioned on opposite sides in relation to the war in Ukraine, just could not bring themselves to avoid saying things and posturing in ways that were bound to upset the other side. And it's super hard for Mr. Guterres, the Secretary General of the UN, or people like myself who are acting as proxies for him on this global crisis, to actually find environments where leadership can be taken. So the G20 at the moment, in all the meetings leading up to the summit shortly, has been unable to come out with agreed conclusions. The G7's doing a bit better, but even there is not the kind of emerging consensus we want. So Marianne, and any suggestions you've got on where the new leadership is going to come from, will be, I think, very gratefully appreciated, because it could well be any one of us who will find the kind of people who are able simply to gather others together and to create the collective energy that is needed to deal with these terrible problems that face our world right now. Marianne, over to you for any further reaction. I don't have an answer.
I think we have to look to the developing countries.
Yeah, yeah.
Because the developed countries have messed everything up beautifully. And that we must look to the future of the world. And in that sense, I've spent 2 trips to I've been in South Africa and in Uganda. And to see what people are hoping for when you get to a very remote village and what they want. And it's very simple. But we seem to be unable to do it. And I think we may have to look to Latin America, or we may have to look to Africa in particular, or maybe, also parts of Asia. But we cannot, without being blunt, well, I am being blunt, we can't go in through food, because that is one of the issues which is a crisis point when you're looking at the Ukraine. And there are so many other entry points, and the complexities, if you put them together, and there are health issues. You've got Ebola now coming back in Uganda. You've got you've got polio again rising. There are so many things, and we need to we have to step back and work out the way in. And it has to be interlinked. And the one thing, and this is my last thing I'll say, the one thing the 2030 agenda, the review that will come up next year is looking at is interlinkages. And there are so many interlinkages in this. And I apologize for speaking so much.
Very good. And it is your right. You are here. And now I'd like to invite anybody who's going to speak just to say whatever they like to say in 1 minute, because we've got lots of comments and I want everybody to get a chance to say so. Denise Van Vissen, please.
Honestly, I'm thinking about lots of things that Marianne said. So yeah, no comment, just thinking. Thank you.
Cool, thank you. Iman Ahmed in Ontario.
Hi, David and everyone. Sorry, I'm just engaged in a lot of stuff at my end, so can't put on my camera today. Thanks for the opportunity. I would like to share a concern, well, multiple concerns from Canada, yes, but as you know, I'm wearing the hat of the developing countries, not only where I grew up, but where I have worked throughout my career. Now, my concern relates to people with long COVID that are now dealing with their conditions with a sense of relativity. So you'd ask somebody I've been following a few of my friends and acquaintances, somebody who had gotten COVID, let's say a year ago or less, and then you do see their lives have been on the decline. Some had stable jobs, they just decided to resign and focus on their well-being. Or they haven't verbalized it, but because they believe and they feel that they cannot perform as before. Yeah. So they have decided to move into the dark, just slide into being private about their illness. The same person you hear later that they developed, I'm sorry, I have a lot of noise over here, but they develop a stroke, for example. Beyond that, they tell you, I am trying to deal with, I got used to not smelling and like loss of smell and taste. But all of this doesn't count when I compare it to the situation, let's say the financial situation in my country. I'm talking about somebody from Sudan or Somalia, the food crisis that other people are dealing with. So people are deciding to think relatively that their long COVID doesn't count. It's not as grave or serious as the other problems facing their countries. And I'm afraid this will continue to mask the long COVID situation.
Yeah. Yeah.
Thank
Gosh,
you.
that's it. That is super interesting. Please, if you can, at some point, text me. I'm going to be in Canada at some point next week, and it'd be nice when I'm on Canadian soil to have a WhatsApp exchange, please.
Indeed, I'll be delighted
Thank
to do
you.
that.
Ian
Thank you.
Boyd, try to be 1 minute if you want to talk.
I don't have a huge amount to add. I mean, I never really say a lot because I'm not a public health professional. I
No.
work in government technology. I mean, we were just talking about misinformation earlier, and I do think this is absolutely key to kind of nudging behaviour, and the kind of behaviours that we see come about through a kind of misunderstanding and fear, essentially. So how can we combat that? We see that people can act positively. The initial reactions to the pandemic, I think community behaviour was stellar. The way people supported one another, the prevalence of people wearing masks we saw in relation to SARS-1 in Southeast Asia shows that we can nudge behaviour. So I think that public health messaging is absolutely critical to getting people to do the right thing. And David, as you always say, people aren't the problem here. It is
It's a virus. Where are you based in?
In London.
Yeah. And what do you do professionally, if you want to say?
I work in government technology. So I used to work on a programme which was providing assistance to shielding patients in the UK. So yeah, I work in government tech. We build digital services.
Very lovely. Thank you. Ad Spikers, would you like to say anything?
Briefly, David, we were very encouraged by your statement last Monday in Rome in the Committee on Food Security. Congratulations, and I think you are, let's say, the forefront. I would say, David, from crisis to opportunity, what are the things also Marianne referred to, but is it not a bit too late if we put it to next year? Every day we see that the number of people here in Western Europe, also in England, in Holland, everywhere, are going to the food bank. It is an extremely contradiction that at the one hand, this is happening, at the other hand, there's so a lot of money spent on weapons every day. It is really frustrating to see what is going on. And the call for peace you did, I think, was very correct one. There is no possibility for development without peace and stability. That were the lessons from Cambodia. They were the lessons from other countries in the world. So, David, I will try to put together a small piece the coming months for a journal in Wageningen, where I try to work out with some colleagues some development data of some sorts. And I would like to share that with you in a translation for your own website.
Thank you.
But we should keep on pressing on things you have done last Monday. And I would very much like that your secretariat maybe can circulate to this group the statement of 12 minutes you made last week in Rome, because that gives the essence of the things which are now played.
Thank you. That's Ad Spikers, who heard the statement I gave representing the Global Crisis Response Group at the beginning of the Committee on Food Security. It was quite long, but I think it was reasonably well received. And Ad's offering, I'm repeating it, Ad, because your sound was a bit garbled. Ad is offering to do a joint thing for Wageningen University, an article in their journal, which I'd love to do with you. It'd be an honor. Thank you very much. You look like you're in daylight, so I think you're back in the Netherlands.
Yeah, yes, we are moving back to Hanoi on next January.
Okay.
But I would also like that the link you have with FAO, this Wolfen program, with others in the UN, because the UN could maybe, what I see, maybe a bit more focused on the development system side. On the politics, David, we cannot solve it.
No, you're saying UN, let's get the UN to do as much as it can because the politics are so bad. Will do. Let's go to Bernice Wittrich, please. Thank you, Ad.
Thanks. I just wanted to introduce myself because I've been on this call for quite a few months and don't really know people. I, like the prior speaker, I don't work directly in public health. I work as a communication strategist, and I work with nonprofits, foundations, and UN agencies. And I really appreciate this call because I find that it gives me grounding and perspective that directly or indirectly affects the work I do, which is work that hopefully in some ways influences public opinion. So just want to say hello and thank you. And at some point, I think this question of the role of food system change and how that interacts with all these different issues, including nutrition and health and COVID, would be worth a deeper discussion, because it's complex and it brings out so many different things.
Beatrice, I know a bit about where you work and who you work with. Would you nobody has to ever say anything about their origins or their affiliations, but if you want to share, people I'm sure would be interested.
Well, really, I work for myself right now. I'm a consultant, and I've worked with, I don't know, many organizations, Rockefeller Foundation, Gates Foundation. I am in Seattle. I work on local justice issues in Seattle, Washington, and yeah, I just, have a deep interest in global health, public health, and agriculture, the environment, and women. So there you have it.
Thank you very much.
David and I met a few years ago at a conference. So that's how I learned about this.
Amazing person. And look, now, I mean, bring others along if you want everybody. At the same time, the intimacy helps. So it's up to you how you do all that. To Rebecca Cantor, please. It's calling in from Santiago. We are truly international here.
Yeah, sorry for coming late. I just finished teaching a nutrition and gardening class. Literally was in the dirt right before this call. I think jumping on what Bernice was saying and somewhat disagreeing with Marianne, I think food systems are critical. Of course I'm biased, but I think we have to go through food systems. I think food systems is what ties us all together. Even if we're just someone who loves to eat food or who needs to eat food to live, we all have to eat. And I think it's such a useful tool. But on that note, I also attended virtually some of CFS 50, and I thought it was also a disappointment. And that's where I would have expected leadership to come out, honestly, because CFS brings together people from all different stages, including a lot of NGOs and actors from developing countries. And I was even shocked by a lot of what the delegates were saying in response to the speeches that were given. I was also involved on the latest high-level panel of experts report on data collection and analysis tools for food security and nutrition. And you might think data collection and analysis tools for food security and nutrition is a benign topic, but the amount of responses that data should still be kept private and not public. We have a long way to go in addressing this sort of poly crisis. But again, I'll emphasize and fight for that food systems is where this all comes together, including how climate change intersects with the COVID-19 pandemic. Again, we all have to eat, and a lot of this should come from more local and resilient food systems. Food systems need to be more localized. We're seeing what happens, the negative impacts of having such heavily globalized food systems. And so I will continue to argue that point, that I think we have to go through food systems. Thanks.
Thank you, Rebecca. So Professor Rebecca Cantor, teacher at a university in Santiago, I never know which one. But
University of Chile.
Chile has been one of the people who's really helped me to understand how food systems connect with so much in society, and was a stimulus to the work that we did to develop food systems dialogues. John Atkinson again, please, then Mahika, and then we will probably end. John, please.
Well, a very quick closing comment from me, and that is I want to applaud something called moral courage that I've seen across a number of people speaking today. Physical courage we're quite used to understanding. That's the I'm not scared, or even if I am scared, I'm going to jump, as it were. But moral courage is the courage to say things that aren't necessarily going to make you popular, messages that aren't necessarily people aren't necessarily ready to receive, or to continue saying things when you're in the face of really quite spiteful and malicious and almost malevolent levels of response. So what's our response to that? Well, there's all sorts of things we can do, but one thing we can do is call out the courage of those who continue to say it, because it distinguishes them from the sort of people who are making those remarks to them. So thank you to all of you who are getting that sort of abuse, frankly, online. I've seen it through our office as well, and I applaud you all. Thank you.
We salute the people with courage who are trying, using their best brains, hearts and souls, to create a world that's better for all. And in the face of so many uncertainties about what COVID's doing to humanity, the work that Ray and others are doing is absolutely key, and we want to do our best to support within whatever assets we've got. Thank you all for coming. To Mahika to make any last comments, and then I want a couple of people I want to say goodbye to.
Yeah, thank you everyone for joining. I had missed the last 2 sessions as I was back in India, where I could really see how COVID, long COVID, and even quarantine had affected some of my older relatives. So coming back to this conversation has been really, really good and thought-provoking. And I mean, we built so many tools to deal with the pandemic, yet we still have problems with our messaging, as Dr. Ray Duncan said, and how doing one thing in isolation is not enough. And as these are interwoven issues, as Marianne mentioned, and how we finally move from crisis to opportunity, as Ad had mentioned in the chat. And for me, this is really interesting. Thank you so much, everybody, for contributing and for giving your stories and experiences. Our next session is on 28th October, so in 2 weeks. If you would like us to edit your comments, share anything else, get in touch with me or Catherine, and we'd be happy to help. Thanks.
Thank you massively. I do need now just to quickly check Gregory Hartle from the World Health Organization. I just realized that I meant to call on you and I didn't. So you get this little extra bit, moment, Ed.
Thank you very much, David. Just very quickly to say that long COVID is certainly the touch point issue for, I think, all of us going forward. And also, as we've seen from the pickup of Dr. Tedros's piece in the series in the Guardian, which is fantastic. It's basically the subject and the way and that will gain attention, and also feature articles, in-depth pieces are really the way to go now. If that translates into any change in attitude, that's another question. Just another thing for everyone to watch out for is that the Emergency Committee on COVID from the International Health Regulations met yesterday, and we are awaiting their statement and decision, which will probably come on Monday. So I don't know, we would not want to see it not continue as a public health emergency of international concern, because that would send all the wrong signals, especially for what we've seen in terms of the lackadaisical approach by almost every country now in terms of good public health measures and any momentum we might be getting in long COVID coverage and action. Thank you.
Thank you very much indeed. Everybody, have a very good evening and next 2 weeks. Real gratitude to you all. Special thanks to Gregory Hartle. He knows why. He's providing me the most amazing support all the time. Big love to Annie and Keith, who were telling me that you might want to tell others that you've got through your COVID successfully and you're in a sort of recovering state. Is that right, Annie and Keith? Good, thumbs up there.